All right, let's just dive right in. If you're getting ready for your anesthesia finals, you already know the pediatric airway is a huge topic. So in this explainer, we're going to tackle this together, cutting straight to the high-yield stuff you absolutely need to know to nail it.
And this, right here, is the single most important idea to burn into your memory. Honestly, it's the foundation for everything else we're about to cover. Getting a handle on these differences isn't just about passing an exam, it's about being safe in your clinical practice.
So, here's our game plan. We're going to start at the very beginning, how the airway even forms. Then, we'll get into the nitty-gritty comparisons between kids and adults, understand the physics that makes every millimeter count, cover the essential gear, and wrap up with the common problems you will definitely see on the exam.
Okay, first up, embryonic development. And I know, it can seem a little academic, but trust me, understanding how the whole system is built from scratch gives you this incredible framework for remembering all the anatomical details that really matter later on.
Now, what's so cool about this is seeing how it all just starts as this simple little pocket in the primitive foregut. Around week 4, this tube forms, and then, it's kind of like a tree, it just starts branching out. You can see these little buds appear, and they just keep dividing and dividing, eventually forming the lungs.
And here's the thing you really need to grasp. This all happens on a super tight schedule, and when these steps go wrong, you get some major clinical issues. So, for example, if those palatal shelves don't fuse right around week 8, boom, you get a cleft palate. Or if the airway doesn't properly separate from the esophagus, you can end up with a tracheoesophageal fistula. See? It all connects.
Okay, so now that we know how it's built, let's get to the heart of the matter. Section 2, the pediatric versus the adult airway. These anatomical differences aren't just trivia, you know? They will literally dictate your technique and your equipment choices every single time.
And wow, this really paints a picture, doesn't it? A neonate's big occiput naturally pushes their head forward, which can close off the airway. They've got a gigantic tongue and a tiny mouth, a short neck, and, this is a big one, they are obligate nasal breathers. Basically, every single one of these features is working against you, making obstruction super easy and getting a good view really, really tough.
Now, let's zoom in on the larynx itself, because this is a classic exam topic. In a baby, the larynx is way up high and forward, at C3, C4. That means you need a straight blade to get under that epiglottis, and here's the critical part. The airway is shaped like a funnel. This means the cricoid ring, which is a fixed circle of cartilage that can't expand, the narrowest point. That's completely different from an adult, where the airway is like a cylinder and the vocal cords are the tightest spot.
Okay, get ready to tattoo this number on your brain. A neonate's oxygen consumption is a massive 6 mL per kilo per minute. That's almost double the adult rate. Combine that with a much smaller lung capacity, and what do you get? They have basically zero oxygen reserve. So during any period where they're not breathing, their oxygen saturation is going to nosedive, and it's going to happen scarily fast. So, that high oxygen demand leads us perfectly into our next section, the physics of it all. This isn't just some boring theory. This is the science that explains exactly why a tiny bit of swelling in a child's airway can turn into an absolute catastrophe. Okay, deep breaths. Don't let the equation scare you, I promise. You don't need to know the whole formula. You just need to remember one tiny but all-powerful detail. Flow is related to the radius to the 4th power. That little r to the power of 4 is everything.
So let's just cut to the chase. For your exam, why on earth does this actually matter in a real-life situation?
This right here is why. It's mind-blowing when you see it laid out. In a baby with a tiny 4 millimeter airway, just 1 millimeter of swelling, that's it, reduces the area by a whopping 75%. And because of that r to the 4th thing, the resistance to airflow doesn't just double or triple. No, it increases by a factor of 16. A 16-fold increase. That's a profound difference and a guaranteed exam point.
And that crazy 16-fold increase in resistance, it leads us straight to our next topic, having the right gear. Getting the size right on the first try is absolutely critical, but hey, don't worry, we've got some really simple formulas to guide us. First up, the classic formula for an uncuffed endotracheal tube in a kid over 1 year old. This is one you'll use all the time. It's just their age in years, divided by 4 plus 4. So for a 4-year-old, that's 4 divided by 4 is 1, plus 4 gives you a size 5 tube. It's simple, it's effective, and it's easy to remember under pressure.
Now for the more modern cuffed tubes. The formula is almost identical. We just tweak it a little bit to make room for the cuff itself. It's age divided by 4 plus 3.5.
So for that same 4-year-old, you'd grab a 4.5 cuffed tube instead. Easy.
But look, picking the right size tube is one thing. Putting it in the right place is just as important, right? The go-to formula for an oral tube is the child's age divided by 2 plus 12. That gives you the depth in centimeters right at the teeth. This is your best defense against accidentally intubating just one lung.
You know, it's also worth remembering that for the really little ones, those formulas don't always apply. So it's a really good idea to just be familiar with a chart like this one for microcuff tubes. As you can see, a term neonate gets a 3.0, an 8-month-old a 3.5, and so on. Definitely worth a look.
All right, home stretch. In our final section, we're going to put it all together. Let's look at the common airway pathologies, because recognizing these patterns quickly is so key, both for your exams and for real-life emergencies.
Okay, think of this as your rapid-fire flashcard review. Laryngomalacia, that's inspiratory stridor. The classic epiglottitis kid, they're drooling, sitting in that tripod position. Croup, you can't miss that unforgettable barking cough. And subglottic stenosis, think biphasic stridor often after they've been intubated before.
And now for the main event. The classic showdown you will 100% see on your exam. Croup versus epiglottitis. Croup is viral, it comes on slowly. You get that barking seal cough, and you see the steeple sign on X-ray. Epiglottitis, on the other hand, is bacterial, it's terrifyingly fast, and presents with drooling. The X-ray shows a thumb sign, and you have to remember, this is a true airway emergency. Your job is to keep that child calm.
Okay, so if you remember nothing else, please remember these 5 things. These are your non-negotiables. 1. Neonates are obligate nasal breathers with that high anterior larynx. 2. The cricoid ring is the narrowest fixed point. 3. 1 millimeter of edema leads to a 16-fold increase in resistance. 4. Know your tube formulas. And 5. Nail the difference between croup and epiglottitis.
So let's finish on this thought. Look, I get it. The pediatric airway can be intimidating. But as we just walked through, it's not a mystery. Once you have a solid grasp of these core principles, that challenge turns into something manageable and, honestly, a really satisfying part of what we do. By the way, everything we've covered today is distilled from this fantastic 2024 article, Developmental Anatomy of the Airway, by Zonde and Howie. I highly recommend checking it out if you want to go even deeper. All right, good luck with your revision.